I'm going to demonstrate how to do the clamping and ligating portion of a spay surgery, keeping in mind that individual patients will require potentially different techniques. This model, as you can see, is see-through, and the reason that we have this model is so that you can see how I'm breaking the suspensory ligaments. And so what I have right here is the reproductive tract. So it's starting caudally, which is at my right hand. Its head is at my left hand. And so what I have here, this first knot depicts where the cervix is, and then there's a Y shape, which uterine body, and 2 uterine horns. There's another knot tied in each side, that's an ovary, and then you'll see the pedicle that's coming down and is clamped into the alligator clip. Part of that pedicle is a suspensory ligament. The suspensory ligament keeps the ovary from being able to be very far exteriorized. It's more prominent in dogs than it is in cats. And so it's a structure that, at least in dogs, you do have to break in order to get better visualization of the ovary and pedicle in order to do some clamping. So in order to do that, we need a handle on this sort of slippery uterus organ. And so the way that we choose to do that typically is to take a mosquito hemostat and we'll grab the proper ligament. And the proper ligament is in between ovary and the uterus. So I'm going to go ahead and clamp that. And then what I'm able to do is palm that clamp and run my index finger down to break that suspensory ligament. So I can either palm this clamp in one hand or the other. What I'm going to do is put some tension on the suspensory ligament. So again, that's why I have the clamp, so I can draw back some tension. And then I'm going to break the suspensory ligament from lateral to medial by placing some tension on it. So I have tension on the pedicle and then some on suspensory as well. And so some of the suspensory ligaments in dogs and cats are very difficult to break, and some of them are a little easier. You'll see after I break the suspensory ligament, then I get pretty good exteriorization of the ovary. At this point, I would do my clamping and ligating. Then I would go down, find the other uterine horn, and break the suspensory on the other one. The way that I would break the suspensory on this one is the same as the first. So I would go ahead and clamp proper ligament, and then I can palm that and hold it as a handle for when I'm going to break from lateral to medial, put tension on that. And so this uterus is stretching a little bit, so I'm going to run the fingers down a little further. I'm going to put some lateral to medial tension on the suspensory ligament, and you'll see that it lets go, and when it does that, now I can exteriorize the ovary and enough of the pedicle to clamp it. At this point, I'm going to switch over to the model that has all of its pieces. And so in this model, the suspensory ligaments have already been broken, but I'm going to go over the clamping and ligating and what it would look like once that was done. So I'm going to remove one horn of the uterus. You can see that the ovary came with it. And so again, what I would have done is clamped proper ligament, broken my suspensory, and then I would have this amount of exteriorization. So now I'm going to do a 3-clamp technique. I'm going to clamp off on the ovarian pedicle because the blood supply is coming up through the ovary from this direction. So I'm going to need to tie this off before I can cut. And I'm going to use 3 clamps, as the name implies, to do that. I can use different sizes of clamps. I can use curved or straight clamps. If I'm going to use some combination of curved clamps and straight clamps, it makes more sense to place the curved clamp distally, that is farther away from the blood supply, than it is to put it proximally. So I'm going to take my clamps and I'm going to place them proximally. You're going to place your clamps with an assistant to hold them, and if that's the case, then you point the clamp handles, the rings, towards your assistant, and you clamp across that entire pedicle. And then see how I'm taking a curved clamp and putting these distally? If I had put a curved clamp proximally, what happens is my 2 clamps start to tap on each other and interfere, and it becomes very difficult to tie or to cut in between them. So instead I'm going to place this one distal. I want them within 5 millimeters of each other so that we don't leave too long of a stump there. And all of them are proximal to the ovary. So at this point, I no longer have need of the clamp, the mosquito that I was using for proper ligament. So if I want to, I can remove it and get rid of it. If I have plenty of clamps and I don't want to take it off, I can leave it on, but I'm going to take them off today. The suture I'm using today is 2O PGA. PGA, the brand name for that is Vicryl. So I'm going to go ahead and open the suture packet. And then when I pull it out of the packet, I'm going to unfold and pull it out of the packet using my needle drivers so that I don't poke myself. And then make sure that I don't pull it out and have the end of it either drop below my sterile field or outside my draped area. So at this point, I actually just need to do circumferential ligatures. I don't even need the needle portion right now. So there's two ways that I can gather my suture. I can either put the needle portion in between my index finger and my thumb and hold it there, or I can bring the needle down just past the base of my palm, not in my palm, but just past it, and close my hand around it. So that's the method that I prefer. There are other surgeons who prefer very much the other, and so you can experiment and see which one works better for you. And then I'm going to have the extra portion of the suture come out on the top. I've got one gentle loop of suture there, so I have not, created knots and lots of loops. So you'll have an assistant, so your job will be a little bit easier. I don't have one today, but we're going to place the first ligature by taking this around the pedicle. And I usually tell students to do the very first ligature as a hand tie because I want to be able to see that you still know how to do a hand tie. And it's easier to remember to do it first. So I'm going to demonstrate the first one with a hand tie. PGA or Vicryl has a little bit of a slippery coating on it because it's a multifilament and the coating helps it to slide through the tissue a little bit easier. This coating makes it slippery when we're not in biologic tissue. And so when we're on these tissues, this is going to be kind of slippery. So for that reason, I'm going to have to do surgeon's or miller's knots to get them tight. My square knots won't do. If I was using different types of suture, I may well be able to get away with just square knots, which you'll see me do as surgeons today. So I'm going to go through and do my hand tie. And then when I pull this throw down, this first throw is going to go in the crush of the proximal clamp. And so what's going to happen is I'm going to remove this proximal clamp and I'm going to make sure that my ligature ends up just about where it was in that crush. I'm going to pull nice and tight, and then I'm going to finish up my next 3 throws. Making sure that I get those throws coming down square. And then I'm going to cut. If I have suture scissors, I'm going to use those. If I don't have suture scissors, Mayos are acceptable. Metzenbaums, the long, skinny, delicate scissors, that would be a no-no to cut suture with those. So at this point, I have one ligature, and because veterinarians are a bit worriers or like to prepare for all things, most veterinarians will put on 2 ligatures. And so I picked up my needle drivers. I demonstrated my hand tie already, so I'm going to do the rest of the ligatures using the drivers. And the second ligature is going to go in between the first ligature and the middle clamp. So in other words, as the blood supply comes from the body up through the ovarian pedicle, first it will reach my first ligature, then my second ligature, and then I'm going to end up cutting in between 2 clamps. So here I can either hold these aside and do a double wrap for my surgeon's throw, or I can form the first throw over top of my finger, depending on preference. And then when I snug this one down in between that area I showed you, I do need to demonstrate flashing of the middle clamp. And so that's an opening and a closing of this middle clamp that will allow me to further tighten this throw. So I'm going to open the clamp. Typically I'd have my assistant do that. I don't have one today. I pull tighter, and then I would tell the assistant to go ahead and close the middle clamp, and they would close it. This helps to tighten the ligature when it's tied close to the clamp. So I need 3 more throws to make this a secure ligature. Okay. And then I can go ahead and cut. Tails are cut about 2 to 3 millimeters, so relatively short. And at this point I have a pedicle with 2 clamps still on it. And so I'm ready to go ahead and cut this pedicle. And I can do that with a scissors, or you can do it with blade. If I do with scissors, I just cut away from myself and away from the patient. If I go with the blade. I want to make sure I'm not cutting down towards my patient, and I don't want to cut towards my own hands. So in this case, often I'll take the clamps back from my assistant if I had one and stabilize the tissue, and then I take the blade, and again it's pointed away from me and away from my patient, and I'm going to slide it along the tissue and cut along that proximal clamp. So at this point I'm going to take this one and just lay it aside. I want to check the pedicle for bleeding before I return it back into the abdomen. If there's enough tissue to grasp it above the clamp, that's what I want to do. If there's not enough, I can grasp it below, but I'm going to go ahead and grasp it above, and I'm going to gently take off that hemostat and make sure I check for bleeding. Keeping in mind that if you are grasped all the way across the pedicle and squeezing hard enough, it won't bleed just because of your thumb forceps. So I'm going to try to just grasp a little bit of it, take a look, and then I'm going to gently return it back into the body if I found that it wasn't bleeding. I use the first uterine horn to follow down to find the uterine body, and then follow it up the other uterine horn so that I've found the second ovary. At this point, I would clamp on the proper ligament and break my suspensory ligament, which again is already broken in this one. And so once I do that, then I can allow better exteriorization of the pedicle for clamping. On this pedicle, I'm going to demonstrate how to do a modified 3-clamp technique. And so the way that we choose to do that is to place 2 clamps on the pedicle and 1 clamp basically distal to the ovary. So actually where this proper ligament clamp is where my distal clamp is going to be. So I'm going to place 2 clamps proximal to that. So in this case, I'm using a straight clamp, so I want to use that proximal so it doesn't end up hitting the curve. And then I'm going to go about 5 millimeters, and I'm going to place my middle clamp. And my distal clamp then is going to be on the other side of the ovary, distal to the ovary. So we use this if we don't have quite enough pedicle to put all 3 clamps on the pedicle. So in the case of a sort of a shorter pedicle, that can be a helpful one. Then I'm going to pick up my suture. And on this pedicle, for the sake of time, I'm just going to place 1 ligature. 2 ligatures would be placed in the same way as they would for the first. I'm going to demonstrate how to do a miller's knot. And so for this one, I'm going to leave a little bit longer of a tail, and I'm going to create an X across my index finger and place my other thumb at the top of the X so it doesn't collapse. I'm going to reach the suture around a second time, and then bring the tail end, which is here, up through the center of the X. And then I put the needle drivers under just the near side of the X, which is now sort of creeping its way out of my hand. Okay, so X, center, and drivers. So now I've got the tail end. Now I'm going to take my finger out so I don't lose a finger in the process of tying a really good miller's. I'm going to remove my proximal clamp, or ask my assistant to do so, and I'm going to tighten down the miller's in the crush of where that proximal clamp was. Nice and snug. This one has a lot of crushing power, so it's helpful for very large pedicles. And then I'm going to go ahead and finish up with 3 more throws. Cut my suture when those are finished. If this were a live patient, my choice would be to go ahead and place a second ligature, which I would choose to do in between the first ligature and the middle clamp. When I did that, I would need to demonstrate flashing of the middle clamp when I pulled the second ligature tight so that it tightened fully, and then I would reclose the middle clamp. At that point, I'm ready to cut. I can cut again with my scissors, or I can cut with my blade. The important thing about this particular modified 3-clamp method is that I have to make sure the ovary goes with the tissue I'm going to take out, goes with the uterus, and doesn't stay any of it in the pedicle, or I get an ovarian remnant syndrome. So I'm going to take my blade, I'm going to cut away from my patient, away from myself, right along that middle clamp, and you'll see the entire ovary here is attached with my, my uterine horn, which is good. I do need to check for bleeding. So if I have enough tissue here to grasp, I'll grab it above the clamp. In this case, I don't, so I'm going to have to grab it carefully below. I'm going to unclamp, I'm going to check for bleeding, and finding none, gently return back to the abdomen. At this point, I have most of the reproductive tract exteriorized, but I do still need to tie off the uterine body because it has uterine arteries that come up along it. So I'm going to follow that uterine body back. I'm going to take my clamps and I'm going to turn them caudally. So in other words, the reproductive tract was sitting this way in the patient. I'm going to flip it caudally and try to find that cervix. And in this case, it's that knot that's right there is what we've depicted it as in the model. So I'm going to place a 3-clamp technique here on the uterine body. The uterine body is thicker tissue. So in this case, I'm going to choose to use Rochester Carmels, where I was using Kelly's mostly on my ovarian pedicles because they were smaller. Within 5 millimeters of the cervix, I'm going to place my proximal clamp. And then each clamp within 5 millimeters of the one before it. Again, I'm placing the rings away from me because if you have an assistant, which you should be practicing with an assistant, they can hold the rings. If I were working by myself, as I am, I would actually be putting the rings towards myself instead because there's no person over here that needs to grasp them. I'm going to place 2 ligatures here on the uterine body. The first one that I'm going to do is a circumferential ligature, so I'm going to choose to do a surgeon's there. Again, I need to do at least a surgeon's on PGA or Vicryl because otherwise it won't come tight. And then I'm going to remove the proximal clamp. And this is now the proximal because blood supply is coming up through paired uterine arteries, and we're following blood supply. And I'm going to pull that down snug in the crush of the proximal clamp. I have 3 more throws to go to make this a secure ligature. And then I'm able to go ahead and place my second ligature. So here on the uterine body, I've placed my first ligature and I'm ready to place my second ligature. Different ligatures will be chosen for different patients based on the size and the suture material and the surgeon. Today I'm going to demonstrate placing a transfixing ligature as a second ligature, but again, individual patients are going to vary on what you choose to place there. I'm going to gather up my suture. Actually, this is one place I'm not going to gather up my suture. I'm going to go ahead and grab the needle and lock my drivers in it, and I'm going to pass the needle through the uterine tissue. At this point, I'll often take the clamps from my assistant in order to hold them, and you can choose to pass the needle down towards the patient or away from. I prefer to pass away from the patient, and I do that because I've seen some people stab their models in trying to go down towards the patient. So you just can lift these up and then go from caudal to cranial through. And then I'm going to go ahead and draw that through, leaving a little bit longer of a tail maybe than what I normally would. So I'm going to create my first throw here is going to be, I'm choosing to do a square here. Square surgeons would be fine. And I've placed that so that ends up on sort of on the side opposite me. So when I make my other knot, my larger knot, I'm going to make it on the side near me. And so in order to do that, because of the way I've passed the needle, I'm going to need to pass the suture around the patient. And in this case, I need to pass the needle around. And then gather again. And now I'm ready to tie the bigger portion, the entire circumferential portion of this. Here I am going to place a surgeon's throw, because again, it's PGA, it's Vicryl, it's a little bit slippery if it's not in live tissue. And then when I pull this tight, I have to do one more thing, or have my assistant flash the middle clamp. So I'm going to open the middle clamp, I'm going to tighten things up, and then I'm going to have my assistant replace the middle clamp. Now at this point, this counts as my first throw. Yes, I know I put a little square one on there, but it's not on this knot, so it doesn't count. So that's my first throw. I'm going to place 3 more throws in order to complete my ligature. If at any point I throw a half hitch, then I'll just make sure that there's 2 good square throws on top of it. If I'm consistently throwing half hitches and having to fix them, then I need to figure out why I'm doing that so that I can adjust my technique. At this point, I can again choose to cut with scissors or with my blade. If I cut with my blade, I usually will take the clamps back from my assistant and hold them with a little bit of tension in between the two. And then I'm going to cut away from my patient and away from my hand. So I'm going to choose to do that this way. And I'm going to put the blade down. At this point, the reproductive tract can either be dropped into a parts bucket sterilely, or if you have a water impermeable drape on your instrument table and your instrument table is big enough, then you can put it back on the instrument table. So I have one more task to do with this before I can return it to the body, and that's to check for bleeding. So if I have enough tissue, I'll grasp it here, distal clamp, which in this case I don't. So I'm going to grab proximal, take a peek at it, it's not bleeding. I'm going to gently return into the body. So that's one method of clamping and ligating the reproductive tract, and at this point, if I had done this in the live patient, then I would proceed on to closing.